if there's something that would create what we call like immediate jeopardy to patient safety, we would most definitely send that through the appropriate leadership channels to correct. That would be an immediate action as an IP to do that. So first would be obviously the department manager, and then any kind of communication above and that we would need to address and explain why this is a breach and why it's so important to get corrected immediately.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Misty Dillon, Manager of Medical Instrumentation Sterile Processing in the Greater Charlotte market. And we're going to be talking about audit procedures today, Larry. And, you know, one of the great things about the IP world is that you get to meet lots of different people throughout either the hospital or the healthcare organization or, you know, the ASC, wherever you're working. And so you get a lot of good engagement, but you also get a lot of nuance and a lot of different scenarios. And, you know, setting up an audit tool and auditing practices, you know, to improve infection control and prevention efforts in your organization is really critical. And I'm interested to be talking to Misty today to get her insights and some best practices. And how do you make sure that not only does the tool work for you, but that you make it work for the leadership and the staff that you're trying to support in conducting that audit?
I think Misty can shed some light for me on what are those best practices of auditing. I think that's going to be really important for our listeners to hear. And what are the specific elements of a typical auditing tool? When we think of a tool, we kind of think of a screwdriver, a pair of pliers, and a hammer. Obviously, that's not what we're talking about here. But I think our listeners will be really interested in hearing about what the elements are. So I'm hoping we can delve into that. And then what hospitals would do when an audit is performed in a particular department, central supply, sterile processing, or maybe an endoscopy department. When a lapse is identified, then what next? What aspect of that auditing dictates what we do next? Do we notify patients? How do we fix the problem? How do we assure that by some certain date that problem is fixed? All this issue of validating the corrective action. I think it's going to be a fascinating interview about auditing. It's something that maybe isn't discussed too much, but should be. And it really is a keystone for infection prevention and patient safety in the healthcare setting.
All right, we're going to be right back with Misty Dillon, Manager of Medical Instrumentation Sterile Processing in the Greater Charlotte market. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
We're speaking with Misty Dillon, Manager of Medical Instrumentation Sterile Processing. And Misty, really excited to talk to you today about audit procedures and successfully implementing those. So thanks so much for joining us on the show today.
Great. I'm happy to be here. Thanks for having me.
Misty, why don't you tell everybody a little bit about yourself and your background? Because I know the position that we just announced to you as your title is actually a new position for you. So get everybody up to speed with what you've done in your career.
Yeah, very, very new. 2 weeks new. So this is my second week in my new role. Prior to that, was a medical laboratory scientist. Did that, worked in the lab for 5 years in acute care. And then I transitioned to infection prevention about 6.5 years ago. Was in infection prevention. Loved it, still love it. Kind of transitioned to this new role now.
Well, there's been an enormous amount of focus on sterile processing, you know, recently, and I've seen all these interesting reporting structures on that. And this is kind of what I wanted to tee you up for, since you're just getting into the role itself. But I've seen them bounce between the operating room leadership and materials management leadership. But there was a big part of me that always thought that should kind of flow up through the infection control organizational, line of the chart. So that way everybody's kind of working collaboratively versus passing a department back and forth that is either looking at the budget and the finances and the savings or the clinical application. I feel like infection control and infection prevention is already in that balance, right? So do you have any thoughts on that, about that reporting structure in the past?
I think a lot of times infection prevention's been left out of that reporting structure, and it kind of shows historically in some of the facilities. I think more people or more facilities and practices are getting involved with infection prevention, especially during this pandemic. A new light has been shed on IP and the IP world in all aspects of the hospital, acute care, ambulatory care setting, including SPD and whatnot. So I think that collaborative partnerships are going to build more and more, hopefully, in the coming years. And probably you'll see the leadership roles more involved with IP, if not an IP themselves or an IP background.
So we have a sister podcast called Beyond Clean, which is focused on the sterile processing industry. And that's something that we always talked about. We had several episodes on it, is who's your partners that you don't necessarily have a direct line to within the organization, but who should you be reaching out to? And infection prevention was a key one for leadership and SPD to really help them improve things in their department. And so when we talk about making improvements, I think that's a great segue to auditing, because auditing is just part of the continuous improvement process. And what's interesting, I think, and unique for infection prevention is you touch all the different departments. So you might do an audit in one place and an audit in another. And, depending on the department you're visiting, you not only can be dealing with a very different culture in the department, but you can also be dealing with very different application of, sort of the infection prevention practices or best practices, I should say. So can you tell us why you think auditing is so important in an organization and what it does for the organization?
Right. So if it's done correctly, in my opinion, correctly is using the data that you get from the audit to drive change. So it should be a continual readiness phase, a tool for that. It should be used to kind of teach the staff. Otherwise, what's the point of doing the audit if you're not teaching the why behind it?
So when you go into those departments, not every department has an educator, but a lot of them do. So when you're talking about this being, such an educational opportunity that's integrated with auditing, if there's an educator that's attached to that department, do you try to engage them as part of the auditing process?
Yes, we do. We try to partner with them. The problem with that is that a lot of the educator positions have been either eliminated or the funding just isn't there to support that role. So who takes that on? Your department leaders usually do, but they can be overwhelmed with all of the departmental pieces of education they have to do. So what about all the infection prevention and the outside things that we can help educate on is what we try to focus on, which includes multiple departments, EVS, plant engineering, the department itself, all these different components go into these audits.
So, Misty, we could speak generally about, as you were saying, about audits in general or infection control audits in particular, and I'll leave that up to you. But you talked earlier about a really important point about getting the data from the audit. And for our listeners, could you explain a little bit when you're performing an audit and you're getting those data, again, whether it's an infection prevention, whether it's a auditing of another department? So how do you collect the data exactly? You perform surveys of staff? What exactly are you doing? If you give us 2 or 3 bulleted items, how do you collect those data?
The data is usually a series of observations and questions. The questions can be directed to the staff and the processes, or just a general observation that the IP makes. So you gather the data based off compliance, whether they're compliant, yes or no. It's very simple, or if it's non-applicable. And then you provide the feedback. Usually you ask a group to go with you, which would include like accreditation, regulatory, environmental services leader for that section, the leader of that section, and then hopefully frontline staff, because those are the people that actually do the work, which usually know the correct response. That information's gathered, and then you send it back to the department leader for follow-up.
So you said observations and questions. What about also reviewing policies and procedures? Let's say staff are adhering strictly to those policies and procedures, so compliance is spot on. But if we back up a step, what if the policies and procedures are written wrong? So while they're complying completely with the policies and procedures, they're actually executing potentially unsafe practices because of tracing it back to the policy and procedures. So what about document review in terms of collecting the data?
Yeah, so you need to make sure that your policies are and your procedures are based off recommendations, best practices, any guidelines from the regulatory bodies. And you need to make sure that the policies are written from a collaborative point of view, so you have all key stakeholders at the table, so you can ensure your policies are correct, so that your staff have an actual best practice to follow when they're doing that. Otherwise, you're setting them up to fail.
Kind of a starting point. So we have the policies and procedures, and are we assuming that they're already correct, or is reviewing the policies and procedures part of this auditing process?
I think that wouldn't be part of the audit. I think you can reference your policies and procedures in your audit tool, so you have something to back up the why for staff, so they can reference something and say, oh, this is why we need to do it that way. I think that should be done prior to doing your audits.
What is that process called when we're reviewing the policy and procedures? Is that also called auditing?
No, that's usually some sort of trail of committees that all those policies and procedures have to go through to get approved. And then they're implemented through whatever the facility practice is.
Through the quality assurance program. Okay,
Yes.
So let's say we're auditing in infection control practices, or specifically endoscope reprocessing procedures. We walk into the endoscopy unit. As you said, we have the policies and procedures established. We start observing, asking some questions, and observing staff. Let's say we observe or identify a significant breach, lapse, deviation. What's next as part of this auditing process of yours?
If there's something that would create what we call like immediate jeopardy to patient safety, we would most definitely send that through the appropriate leadership channels to correct. That would be an immediate action as an IP to do that. So first would be obviously the department manager, and then any kind of communication above, and that we would need to address and explain why this is a breach and why it's so important to get corrected immediately.
And then you might review the policies and procedures and see to what degree did that breach rise in terms of a safety issue, where you might then notify patients, or ideally you wouldn't have to notify patients. But that notification process is probably part of that policy and procedure. Is that correct?
Yes, that is correct. And any follow-up, tracking back retrospectively, looking at if any patient harm was done prior to, and then also going forward, if there's any patients that had an effect on, we would look at those patients and monitor them as well.
That would not be part of the auditing process per se. That would be handing the baton to someone else, though.
Correct.
So you mentioned the audits and the tools, right? And so I'm assuming that in many cases that audit tool is in existence, but I'm sure you audit the audit tool or at some point you review it and modify it and enhance it. But if somebody is kind of out there and they're in a position, and you mentioned like ASCs and, you know, sometimes in that non-acute setting as well, if anybody's practicing there, and they may find themselves really with a lack of auditing tools. They might have policies and procedures, but the auditing tools might not be there. What are some resources that they can go out and seek out to help them, you know, build those kinds of auditing tools other than maybe going to an APIC meeting and talking to colleagues to try to say, hey, can I borrow your tool from your employment, to help me in mine?
So the CDC actually has a lot of toolkits for environmental rounding, which encompasses a lot of what IP focuses on. And there's a lot of questionnaires from, like, AORN has other tools that you can look at, but CDC would be a good place to start. And even your own IP within your facility I would say would be the first place I would start. They're just a bucket of resources, and they can help you with that.
So you mentioned the tool and grabbing the data, and you started to talk a little bit about the teaching moment and presenting those findings back to the department. But I want to talk about how you present it, like the strategy for that, because if somebody's not receptive to being educated or they're certain that they're right, that can be a real challenge for you actually achieving what you hope to achieve from the audit, and especially if you find that there's a lot of gaps in process. So what are some ways that you can strengthen your relationship with those departments, make sure that it's non-confrontational, but also make sure that when they get that information that they really take it to heart?
Right. And that's a good reason why you would want a leader there present with you, whoever's responsible for that area, because having them walk through with you really helps open their eyes to things that maybe they didn't know, or they didn't understand the why behind it should be done this way or that way. And that helps build those relationships that you're mentioning. Another thing is to not be punitive. Don't go in and just, immediately tell them everything they're doing wrong. That's the best way to end a relationship before it starts. So you want to go in friendly and open and tell them, what you're there for, to start building those relationships. And be there as their backup if they ask you as a resource. Make sure you're available to them to help them.
So the leader is going to champion what you're bringing to them. But then at the same time, if they get pushback, you then become a resource to them, a third party that sort of validates something that maybe even the IP had already brought to the table to begin with, and they were just making sure it was getting executed, in their area of the hospital. So we talked about the tools. You told us where there were some resources. You talked a little bit about gathering data and really how to present that and get engagement from the audience that you're working with. But as far as the actual audit itself, what are some really key elements and key components for those audits? And I'm assuming they're all addressed in the audit tool because it's guiding you through that. But ultimately, what cannot be left out?
So some must-haves, I would say, would be reference guidelines and your facility's policies. That's always helpful. It gives the auditor some leeway and a tool of reference to use when they're speaking to staff. Have a clear format. Clearly a simple, easy to read format. And I recommend doing it all in one document. So you have your audit question, your department that's responsible for that section, and then any follow-up or comments that the auditor made, and then a place for them to clearly provide corrective action if needed from that department. So it's all one big document that can easily be read.
Are checklists a part of this whole process in that one document you're talking about? So as you walk through the audit as an audit tool, are checklists routinely helpful?
There are generic checklists that we send out, not necessarily from the IP department, but the health department has a really good readiness checklist. I know in a different facility I was at, we actually did do a pre-audit checklist, so they knew kind of what we were going to be looking for, and they could kind of go through and check it off in their department prior to our arrival.
Okay, so I think for the listener who might have thought auditing wasn't so important to public health and patient safety, we're learning even more and more today how much it really is, and I appreciate all the insights you're giving. There are a number of questions based on just what we're talking about today that I hadn't thought of necessarily before, but I'd like to just ask you now. And one goes to the issue of frequency of audits. So let's think of a paradigm where with steam autoclaves, let's say we identify a lapse, a deviation, something with the steam autoclave is not working. So we've done an audit, we find out it doesn't work, maybe through a biological indicator that failed. We fix it, and then right after that, we perform another set of biological tests to confirm whether we properly fixed the sterilizer. So let's take that into the world of auditing now. Let's say you perform an audit, you identify a breach. So the first question is, how often per year do you perform the audit? And then do you perform an audit when you identify a breach? Do you then perform an audit right after the corrective action has been implemented to confirm that the breach is no longer there and the corrective action actually works, that you validated the corrective action? Can you address that a little bit?
Sure. So frequency is really dependent upon your facility. Most facilities want you to do clinical areas twice a year and your non-clinical once a year. I like to audit more frequently because A, it builds those relationships, and B, you want to always be in that continual state of readiness on your area. So I was doing monthly in my clinical spaces and quarterly in my ancillary type spaces. So that gives them time to answer any corrective action from last month, and I expect to not see it again on the next month unless there's something, hindering it from being compliant, like they're waiting on a part to ship in to fix whatever or whatnot.
So you would then specifically look in a subsequent audit, you would look back as part of your auditing tool maybe of previous audit results and see if something was not being performed properly and then confirm and revalidate now that it was being done properly. Is that part of the audit process of kind of tying the loose end from the previous audit?
Yes, I always check the audit prior to going out and re-auditing, and I color code mine just to make sure that it's visually easy to read. So red is bad, I go straight to that, make sure that I know this is what they said they did to correct this action, and I'm going to make sure that they do that on the next audit.
Okay, Misty, you said earlier about the issue of punitive, and you said that when people make mistakes, it's important not to come down on them hard and to have punishment as an element of that. And I know you've talked a lot in some news articles I've read about flus and flu vaccinations. I'm wondering what you think about mandating vaccines, flu vaccine, COVID vaccine, and punishing or reprimanding those who maybe don't agree with that instruction or requirement, which would be inconsistent with what we talked about earlier, where our model kind of is not to be punitive. So where do you see public health moving forward? Is there a role for punishment, or should we always maintain that non-punitive, supportive stance?
Wow, that is a tough question, Larry.
I've been always been taught the non-punitive, and all of a sudden now I'm seeing bad. You didn't get, and I read a recent CDC report where they kind of were admonishing a teacher because they said she didn't get vaccinated. And I'm wondering where public health is going. But I think it really is an important point to discuss, not necessarily answer, but what is the role of punitive kind of actions by a higher authority with regard to vaccines. So as I said, it may be something you want to defer and not talk about now, but I think it's something really cutting edge, and I think it's an interesting topic when we talk about that. So what are your thoughts?
Yeah, I appreciate the question. I just think a lot of good people have left healthcare because of it, and that's sad. And we've lost a lot of IPs because of it, believe it or not. A lot of people have left, and it may not be because of the shot. It may just be the overwhelm and burnout from COVID itself.
An important distinction.
Yeah, I think that's the main thing, because most IPs will agree, I'm vaccinated, okay? I am. I thought long and hard before I got it.
Right.
And then my facility mandated you have to, or you get, let go.
Misty, thank you for sharing your thoughts on that. That is not an easy conversation, not only for individuals to have, but also healthcare organizations. I almost feel like that's a podcast discussion in and of itself. But I do want to bring us back, just to the auditing piece. The one thing that, I think is hard for audits, and you alluded to it, or really any process, but you alluded to it by saying, I'm going to do this quarterly and then I'm going to come back. And I guess sustainability is the biggest key, because those teachable moments, it's not like you just fix it and then it's done forever. Like new staff come in, and we just talked about the turnover and the stress that is in the industry. I mean, people have not continued to do their jobs because they're just burnt out being in healthcare because the stress level is so high. And so that means lots of new staff or not enough staff. And so even, are they really in a good frame of mind to be learning just based on how their workday is going? And so it's all about the reinforcement of whatever you're teaching, whatever you're learning from the audits. And I'm just wondering, other than setting them up to be quarterly, especially if we're talking to somebody who is stressed out and understaffed in their department and just trying to keep up, how do we make sure that this is a sustainable process? And can we engage other stakeholders throughout the organization to make it sustainable with us?
So that's the $1 million question, sustainability, and how you get into this steady state of being where you want to be in your facility. And you're right, Justin, you need the leadership from the C-suite down. You need their support. I cannot tell you that enough. You need their support, because if they don't set the expectation at that level, it won't work. You have to have that support. If you do have that support, and what you can do as the IP or as the auditor is have clear expectations, clearly define what roles people play in the audit, and then in the corrective action plan for the audit, and just have consistency and collaboration, a lot of collaboration, and answer questions for your unit directors or managers or whatever type leadership they may be.
You said that it was really important a lot of times for that leadership to have you as their support. And I like the way you said hospital leadership is going to, play the same role for the IP when they're going through the auditing process. What I'd like you to do now is just give us a real world example. This is really our last question. And I just thought maybe you could, I don't want to make it like it's story hour, but if you could just tell us, describe a scenario from your real life experience about how you went through the auditing process, and really like because what I would think about as an IP, if I'm trying to present this, is there may be hesitation to go do the audit depending on just how outgoing that individual is. There's, just their general soft skills and demeanor to go out and start working with, I've got this one department and the leader in there is scary, right? So I want to make this process, I want them to be able to visualize success with this process. So can you tell us what that looks like?
Sure. A few years back, started another facility as their new IP, walked in knowing that sterile processing had not the best Joint Commission survey previously, and there was some opportunity. Well, in an IP's eyes, opportunity means we need to teach, educate, audit, get the data, keep rolling with it until they are ready. So I'm notorious for auditing and asking really hard questions to brand new techs in sterile processing. So you can see them day one on audit month one, they're very nervous. They don't look at you in the eye. They shake. They're like, they avoid you, really. So what are they going to do when an actual surveyor comes in, right? They're going to just run and hide. And that's not what we want. They know the job. They should be proud of what they do, and they should hold their head up when they speak with confidence, no matter who walks in the door. And as the months went on, the change happened. The audits were helping them, empower them to be confident. They were spitting off answers. It was just wonderful to see. And it's all because you took the time to teach and ask the questions. Something so simple as that. It's really helped staff to grow in their professional self, and it was really great. They actually had Joint Commission come back for their triennial survey, and there were no SPD findings in that department. So that is pretty amazing from any standpoint, IP or any standpoint for sterile processing.
Helping them know that they should have confidence in what they're doing, but seeing it measurably is really about building self-advocacy. And a department like SPD or environmental services, dietary, some of these areas where, a lot of times the workforce feels like they don't have a voice, or they may not be as appreciated as a revenue generating department does. And so they still have to be able to stand up for themselves when they know that they are, guided by recommended practices, industry regulation, guidelines, etc. They have to be able to stand up. And the Joint Commission survey is a great example. And so giving them that self-confidence, that ability to self-advocate, and what that does for the entire department and how that makes the leader look is really just a great way to look at how these audits can help, because you'd rather be prepared than get caught and all of a sudden you're on your heels, and it's really hard to get firm footing again after that. So, Misty, great job in this interview. Do you have anything you want to add before we wrap up?
Thank you for the opportunity, and to all those out there in the podcast world, make friends with your IP. They will be a great resource for you.
That was Misty Dillon, Manager of Medical Instrumentation Sterile Processing at Novant Health Greater Charlotte Market. And we talked about audit procedures, how to implement them, how to do it successfully, some best practices and resources that are available to you. And then ultimately, how do you make it sustainable? How do you keep it going? And especially in today's environment with, really a difficult staffing situation, not only in IP, but in all the multiple departments too. So it's not just, do you have the people to do the audits? It's once you've done the audits, to benefit from them, you've got to present the feedback to those departments. And do you really have the staffing in place for people to really be receptive to that information and then implement, those changes and best practices in their area of the hospital, Larry?
Yeah, and I think, Justin, that's something that is really crucial to patient safety and quality control, is whether these audits maybe are not as efficient as they used to be, which then could potentially cause some infection control problems. But I guess in time we'll learn more and more. But you bring up a really good point that to perform audits, you have to have staff. And if we're losing staff, audits are going to suffer. And if audits suffer, bad practices are going to start to peek their head. And I'd be interested in our keeping an eye on that and seeing how that all plays out. I think we talked about a number of other interesting topics, such as the frequency of how often you would audit, and what you would do if you identified a significant lapse that maybe would pose a risk to patient safety. Would you then notify the patients or not? And we talked a little bit about punitive actions in public health, and how is public health moving forward? What is the new hat that it's wearing, or does it keep the old hat where we're very supportive? Or when we see things deviating, do we then, from the top down, do we start punishing dedicated staff members? So that's never been what we've done, and I'm wondering if that's where we're going.
All right, well, that's going to do it for this week's show. As a reminder, you can help support Transmission Control by subscribing on Apple, Amazon, or Google Podcasts. We're also available on Stitcher, iHeartRadio, Spotify, or just search for Transmission Control on your favorite podcast app. You can also access bonus content for certain episodes, but you're going to download our smartphone application for iPhone and Android. We'd certainly appreciate a rating and a review while you're there, because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.